Welcome everyone, my name is Eliza Tóth and I work for Pannon Business Network Association in Hungary. Today I will present in this presentation the main findings of the RehAllianCE National Programs and Guidelines Assessment. The analysis looks at how rehabilitation technologies are financed, regulated, supported and integrated into health systems across 5 partner countries: Austria, Germany, Hungary, Italy and Poland. The focus is not only on describing each national systems, but also on understanding what makes a rehabilitation ecosystem ready for innovation. In other words, the assessment helps us see why some countries are better prepared to adopt digital tools, telerehabilitation or robotic technologies, while others still face structural barriers. The assessment was prepared to understand the policy and financing environments behind the rehabilitation technologies. Partners worked with a shared research template, which made the country findings comparable. The template covered national and regional policy objectives, rehabilitation programs, key institutions, public and private funding mechanisms, government initiatives, research and innovation support, and cooperation between public, private, and non-governmental actors. It also mapped the regional medical technology ecosystem, including companies, research centers, care providers, patient organizations, regulatory actors, and funding partners. Finally, partners collected strengths and weaknesses, good practices, mistakes and lessons learned, and concrete innovation support schemes. This means the report is not just a policy overview, it is also a practical mapping of what can support or block the adoption of new rehabilitation technologies. After this common methodology, let us look at the country-specific findings. Austria represents one of the most mature systems in the assessment. Rehabilitation is mainly financed through mandatory social insurance, with different insurance institutions responsible for work capacity rehabilitation, outpatient rehabilitation, and post-accident rehabilitation. A strong feature of Austria is that rehabilitation is embedded in structured governance. The federal level sets the strategic direction, while regional authorities adapt and implement services. Austria is also active in digital and robotic rehabilitation, for example, through telemedicine programs and centralized procurement of rehabilitation technologies. However, the assessment also shows that even mature systems face practical barriers. In Austria, these include rural access gaps, workforce shortages, and sometimes slow or complex financing pathways for new technologies. So Austria gives us a good example of a strong system where the next challenge is not basic coverage, but faster and more equal innovation uptake. Moving from Austria, Germany shows another mature model, but with somewhat different logic. Germany is another high maturity system. Its strength lies in the combination of strong legal framework, statutory insurance-based financing, and a dense innovation ecosystem. A particularly important principle is rehabilitation before disability pension, which means that rehabilitation is understood not only as a healthcare, but also as a way to preserve workability and social participation. Germany is also an interesting example for digital health because it has created a fast-track route for certain digital health applications to be prescribed and reimbursed. At the same time, the report highlights an important paradox. Germany has many pilots, clusters, and innovation projects, but moving these innovations into everyday rehabilitation care is still difficult. So the German case shows that innovation systems are essential, ecosystems are essential, but they need clear bridges into reimbursement and routine care. The next country, Hungary, has strong innovation potential, but the main barriers are more related to financing and implementation capacity. Hungary presents a more mixed picture. The country has important foundations. Rehabilitation is financed mainly through the Hungarian Public Health Insurance Fund. Inpatient rehabilitation uses a daily rate model, and outpatient care is covered through public contracts. Hungary also has strategic documents such as the National Musculoskeletal Program and Healthy Hungary. A very interesting strength is the country's medical technology and clinical research background, supported by cooperation between universities, companies, and innovation networks. However, this innovation potential is not yet fully translated into patient-level access. The main barriers are chronic underfunding, hospital debt, workforce migration, and the widening gap between public and private care. Digital and telerehabilitation pilots exist, but nationwide implementation is still limited. Hungary's central question is therefore how to connect its research and industrial capacity with stable public financing and accessible rehabilitation services. Italy, in contrast, has a very strong right-based model, but faces another type of challenge, regional inequality. Italy is particularly interesting because its legal and philosophical foundation is very strong. Rehabilitation is linked to the constitutional right to health and part of the universal national health service. The Italian model also has a clear patient-centered orientation, using individualized rehabilitation plans and biopsychosocial approach. Italy is active in robotics, telerehabilitation, and outcome monitoring. The new rehabilitation discharge reporting system is important because it includes functional indicators and can support more data-driven quality monitoring. The main weakness is not the lack of rights or guidelines, but uneven implementation, because northern regions tend to have stronger infrastructure and innovation capacity, while southern regions and islands may face more limited services, longer waiting times, and healthcare migration. Italy therefore shows the strong legal principles are not enough if implementation capacity differs significantly across regions. The last country case is Poland, where the key issue is broad but fragmented financing. Poland has a broad but fragmented rehabilitation financing structure. Medical rehabilitation is financed by the National Health Fund. Occupational rehabilitation is supported by the Polish Social Insurance Institution, and social rehabilitation is supported by the State Fund for the Rehabilitation of Persons with Disabilities. This means that, on paper, Poland covers health, workability, and social inclusion. The Silesian region also has strong academic, clinical, and technical potential, which can support rehabilitation innovation. Recent robot procurement and digital health funding schemes show clear interest in modern technologies. However, the main challenge is sustainability, because coordination between financing bodies is weak. Many initiatives are project-based, and the system relies heavily on European Union funding. This creates a risk that new equipment or pilot projects may not be maintained or scaled after project funding ends. After these 5 country snapshots, we can now step back and look at the comparative findings. The comparative report brings the 5 systems together across 5 main dimensions. First, financing models differ. Austria and Germany rely strongly on statutory insurance. Italy has a universal public healthcare model. Hungary relies mainly on its public health insurance fund. And Poland uses a 3-pillar structure covering medical, occupational, and social rehabilitation. Secondly, legal frameworks also differ, because Germany and Austria have highly structured institutional systems. Italy has a strong rights-based model, while Hungary and Poland have policy frameworks, but more difficulty with implementation. Third, the supported technologies include robotics, telerehabilitation, digital applications, and remote monitoring, but these are not equally integrated into routine care. The research and innovation support depends on ministries, regional development funds, universities, and medical technology clusters. The public-private cooperation is strongest where there are structured platforms or insurance-based contracts. The weakest where cooperation remains ad hoc. The key observation is that rehabilitation technology adoption depends on the alignment of financing, regulation, innovation, and cooperation. This leads us directly to the gap analysis. The gap analysis compares national practices with international recommendations, especially the directions of the World Health Organization's Rehabilitation 2030 agenda. All 5 countries recognize the importance of rehabilitation, but the assessment shows a clear distance between strategic goals and practical implementation. The most common gaps are workforce shortages, unequal regional access, financing instability, and fragmented care pathways. Digital and robotic tools could help address some of these problems, but only if they are supported by reimbursement, training, and clinical guidelines. Particularly important observation is that stable financing is not only a budget issue, it is also a system readiness issue. Without long-term financing, promising pilots projects remain isolated and do not become part of everyday care. So the main challenge is not only whether technologies exist, but whether the system is ready to finance, integrate, and sustain them. The maturity system analysis helps us understand this system readiness more clearly. So moving on to the system maturity or cluster analysis, it groups the 5 countries according to system maturity. Austria and Germany are high maturity systems because they have long established institutional structures, broad insurance coverage, legal guarantees, and more stable financing. Italy is a medium or transitional system. It has universal access, strong rights, and holistic rehabilitation model, but regional disparities prevent uniform national performance. Hungary and Poland are developing maturity systems because both have important foundations and innovation potential, but they face resource shortages, workforce problems, fragmented implementation, and dependence on project-based or external funding. This slide is useful because it turns a complex report into a clear message. Countries do not only differ in the technologies available, but also in their ability to absorb and sustain innovation. After understanding maturity levels, the next question is not simply which country performs better, but what each country can do next. This is where the analysis moves from SWOT to TOWS. After the country-specific analysis and the gap and maturity and system maturity analysis, the assessment does not stop at describing strengths and weaknesses. It goes one step further and uses the TOWS logic to turn the findings into action-oriented recommendations. In simple terms, the question is, what can each country build on? What should it protect itself against? And which opportunities can help overcome existing weaknesses? This is important because the same issue can appear in different forms across countries. For example, workforce shortages is a common problem, but the response may be different in Austria, Hungary, or Poland. Similarly, digital rehabilitation is a shared opportunity, but its success depends on whether financing, training, and regulation are ready to support it. The TOWS approach, therefore, helps translate country-specific findings into more strategic directions. On the next slide, I will show this through short country snapshots, one asset, one risk, and one strategic direction for each country. For each country, we highlighted that there are positive advantages, there are risks or tensions, and combining them, there could be possible strategic directions. Austria can build on strong public financing and coordinated governance, but rural access and workforce shortages remain challenges. Therefore, the strategic direction is to expand rehabilitation, mobile services, and faster reimbursement pathways for proven technologies. Germany has a strong legal and innovation base, but many pilots still struggle to enter routine care. The strategic direction is to mainstream digital rehabilitation through reimbursement, clinical guidelines, and professional training. Hungary has medical technology and clinical research potential, but this is limited by underfunding and workforce migration. The strategic direction is to connect innovation capacity with more stable public financing and better regulated public-private cooperation. Italy has a strong rights-based and patient-centered model, but regional fragmentation weakens equal access. The targeted support for the strategic direction is to introduce stronger national minimum standards and targeted support for weaker regions. Poland has strong regional innovation potential, especially in Silesia, but the system remains too dependent on project-based and European funding. The strategic direction is to strengthen national coordination, long-term financing, and stakeholder platforms. The common message is that every country has something to build on, but each also needs a clearer mechanism to make rehabilitation innovation stable, accessible, and sustainable. The TAOS analysis bring together the country-level findings and translates them into broader strategic priorities. The TAOS analysis leads to 5 strategic priorities. First, countries should reduce regional inequalities through minimum standards, targeted funding, and better monitoring. Secondly, workforce development is essential because rehabilitation technologies cannot be used effectively without trained professionals. Third priority is that digital and robotic innovations need clearer pathways into routine care, including reimbursement, guidelines, and training. The fourth priority is financing should become more sustainable so successful pilots can continue after project funding ends. The fifth priority is stronger cooperation platforms, which are needed between public authorities, financing bodies, providers, researchers, companies, and patient organizations. For the next phase of the RehAllianCE project, the assessment can support strategy development, stakeholder validation, planning, and pilot design and policy dialogue. So the report should be used as a bridge between evidence and implementation. To close, the assessment shows that Central Europe already has strong examples, promising innovation capacity, and shared challenges. Austria and Germany demonstrates how stable financing and strong governance can support mature rehabilitation systems. Italy shows the value of a rights-based, patient-centered model, but also the importance of reducing regional inequalities. Hungary and Poland show that innovation potential exists even in less mature systems, but it needs stronger financing, workforce capacity, and coordination to reach patients. The most important message is that rehabilitation technology is not only a technical issue. A robot, a digital application, or a tele-rehabilitation platform creates real impact only when reimbursement, regulation, trained professionals, and care pathways are aligned. This is where RehAllianCE can add value by turning comparative knowledge into practical cooperation, validated strategies, and more equitable access to rehabilitation technologies. This is where I ending my presentation, and thank you for your attention.